Hello, my name is Kalantar-Zadeh. I'm a practicing nephrologist and professor of medicine at the University of California, Irvine. Today's talk is titled Beyond Binders, Emerging Mechanisms of Phosphate Lowering in Patients with CKD on Dialysis. Phosphorus is element number 15. Phosphorus has 15 protons, 15 electrons, 16 neutrons, and has an average atomic mass of 31. So as noted here, phosphorus is abundantly present in dietary proteins, which we're going to talk about soon. Here, we're highlighting the reason why serum phosphorus, that means the level of phosphorus in the blood or serum, is important in patients with CKD on dialysis. This is a classic study which shows that as levels of serum phosphorus is higher, mortality in patients on dialysis is also higher. And now you're comparing these two large studies from two distinct dialysis providers, showing that no matter where the patient is or where the data come from, the association of higher serum phosphorus with mortality in this incremental format is consistent. So that higher phosphorus is associated with higher mortality. Looking at this data, this is epidemiologic data showing over 100,000 patients on hemodialysis across different age groups, suggesting that no matter what the age of the patient is, 15 to 45, 65, 70, 75, or even older than 75 years old, higher serum phosphorus is associated with higher mortality. And these data, as suggested, are relatively consistent. So now, in this New England Journal of Medicine, which was published in 2017, we highlighted mechanisms that lead to the absorption of phosphorus. And this is a schematic presentation suggesting that phosphorus is absorbed from the source of dietary proteins. And excess phosphorus could lead to vascular calcification. So that could be one mechanism why higher level of phosphorus is associated with higher mortality. Also, phosphorus in its more abundant format could lead to bone damage, also known as kidney bone disease or renal osteodystrophy. Now, as to how phosphorus is absorbed, I would like to highlight one message, and then we go to more details. And this is about the role of vitamin D. So studies have shown, such as this one, that the higher is the level of vitamin D or amount of vitamin D in a given patient, the higher proportion of phosphorus of the food is absorbed. So that in this example, phosphorus absorption goes from 60% to 86%. Therefore, intestinal phosphorus absorption is an important factor that can be modulated. Now, let's move on and see how this happens. So here, dietary phosphorus absorption occurs in the gastrointestinal tract through two distinct clinical pathways or physiologic pathways: paracellular transport and transcellular transport. So as to which one is more important for the control of phosphorus, we're going to go over the next few slides. The transcellular pathway is less physiologically relevant in a phosphorus absorption in human. Although NAPI2 has been established as a major phosphorus transporter in rodents, based on human studies, the transcellular pathway contributes less to total phosphorus absorption and is therefore less physiologically relevant in phosphorus absorption in humans. Evidence demonstrates that the paracellular pathway, as shown here, is the primary mechanism of phosphorus absorption in the gastrointestinal tract. In contrast to NAPI2, paracellular phosphate absorption does not saturate. Rather, paracellular phosphorus absorption increases in a linear fashion with increasing phosphate concentration gradient, as shown here. So the so-called sodium hydrogen exchange 3, NHE3, is a sodium proton countertransporter. And this transporter facilitates the absorption of sodium in exchange for cellular proton. NHE3 is the predominant NHD contributing to sodium absorption in the small intestine. And deletion of NHE3 in mice has been shown to reduce paracellular absorption of phosphorus. Now let's move forward and look at what guidelines say. Kidney Disease Outcome Quality Initiative, known as KDOQI. These are guidelines that recommend in patients with CKD stage 5 on dialysis, serum levels of phosphorus should be maintained between 3.5 to 5.5 milligrams per deciliter. And then there is another guidelines body known as KDIGO, Kidney Disease Improving Global Outcomes. They recommend in patients with CKD stages 3A to 5, lowering serum phosphorus should be achieved in the normal range, as shown here. So in theory, there are ideally 3 basic approaches to hyperphosphatemia management in patients with CKD on dialysis. One is dietary modifications, that means telling patients to eat less or to eat differently. And the other one is increasing frequency of dialysis. And the third one is using phosphorus binders. Now, as shown here, there are a number of phosphorus binders that have been developed over time. These are medications that bind phosphorus in the intestinal tract, and 5 of them are mentioned here. It's important to know that dialysis patients take on average 12 to 19 medications. So this is one of the studies suggesting that patients with CKD stage 5 on dialysis suffer from a number of health problems, including pill burden. Now, as shown here, phosphorus binders, the number of pills that are related to phosphorus binding treatments, they are almost half of all the pills that patients on dialysis receive. All right, so now let's look at what we could do. As a class, phosphate binders act by binding dietary phosphorus to form insoluble complexes that pass through the GI tract, thereby reducing phosphate absorption. And this is true for all phosphorus binders we discussed. Phosphorus binders, they do not target or act on phosphorus absorption pathways. They simply bind dietary phosphorus in the GI tract. So therefore, due to the short duration of action and limited binding capacity per pill, the binding mechanisms often require large tablet size, dosing multiple times a day, or each time patient eats. And as discussed, on average, 10.8 pills per day. And phosphate binders account for half of the daily pill burden for patients on dialysis. All right, now this slide is coming from the New England Journal of Medicine paper highlighting the recommended dietary and nutrient intake according to CKD stages, suggesting that the amount of phosphorus intake should be less than 800 milligrams per day overall. However, when we look at this slide that suggests phosphorus estimations, if patients is targeted or is required to have higher protein intake, which is very important, the dietary phosphorus intake also increases to above 1,200 milligrams per day. And if dietary phosphorus intake is restricted to less than 800 milligrams per day, then the dietary protein intake is going to be restricted, which may cause harm. So therefore, we have a conflict here between the recommended dietary protein intake, which is important to be high, and dietary phosphorus intake, which is supposed to be low. And this as well as other studies and commentaries, as well as such as this one, dietary restriction in dialysis patients, is there anything left to eat, highlights the challenges. That means inadequate protein intake, risk of protein energy wasting, which may lead to low serum albumin, and leading also to patients' dissatisfaction and inferior quality of life if patients is always restricted in terms of food intake. This study by Schieneberger et al. Shows that the best combination would be for a patient on dialysis in terms of phosphorus control versus protein intake is when protein intake is increased while phosphorus level in the serum is decreased, as compared to lowering serum phosphorus level by means of dietary restriction. And I'm going to highlight the other study also by colleagues, including Dr. Lynch and colleagues, suggesting that there is an association between prescribed dietary phosphorus restriction and mortality, in that a higher restriction is associated with poor outcome. In this study of over 1,700 patients on dialysis from the HEMO study. And this is the slide about the molecule Tenapanor and intestinal phosphorus absorption. Tenapanor is a minimally or systematically absorbed inhibitor of intestinal sodium hydrogen exchanger 3, which we call NHE3. It reduces phosphorus absorption in healthy persons and lowers elevated phosphates concentration in patients on maintenance hemodialysis. The effect of tenapanor on phosphate absorption is mediated by transiently increasing the intracellular proton concentration in cell lining, and that's in the gastrointestinal tract, a result of NHE3 inhibition that we showed in previous slides. And this leads to conformational changes in the tight junction of these intestinal cells. And as a result, stool sodium and water content are increased, leading to loosening stool consistency and increasing bowel movement frequency. To examine whether tenapanor works on lowering serum phosphorus in dialysis patients, a number of studies were done. This is a phase 2b study. It's a randomized, double-blind, placebo-controlled study in adult CKD patients on hemodialysis and having hyperphosphatemia. In this dose-finding study, there were 7 groups of patients. So nearly 600 patients were screened, and then patients were randomized after a washout period of 3 weeks. 1 to 3 weeks, patients were randomized in one of the 7 groups, including one of the groups being placebo group, and tenapanor from 1 milligrams BID to 30 milligrams BID as well as QD were given to each of these 6 distinct tenapanor groups. Now here you see the demographics of these 7 groups of patients, including placebo, where there were 26 patients, as well as the 6 tenapanor groups. On average, the age of these patients were between 56 and 62 years old. So as you can see here, patients' demographics are relatively balanced, in a balanced distribution across 7 groups of placebo plus tenapanor dose and frequency variabilities. And this slide highlights the results. As shown here, tenapanor with higher dose was more effective in lowering serum phosphorus level. So the best dose being 30 milligrams BID in terms of lowering serum phosphorus. So tenapanor treatment resulted in dose-dependent reductions in serum phosphorus. And the largest dose reductions was observed with higher dose and frequency. Now here we are looking at the adverse events. Overall, 94 patients or 58% of the patients experienced at least one adverse event during this study. 28 patients discontinued due to adverse events. Most frequent was diarrhea in 19 patients. Now, one important finding in addition to lowering serum phosphorus was also the effect of tenapanor on FGF23 as an important role player. So you're looking at geometric mean serum of FGF23, and as shown here, during the washout period, the first 1 to 3 weeks, serum FGF23 is increased. But then during the 4 weeks of tenapanor therapy, FGF23 was reduced effectively as compared to placebo, where FGF23 continued to increase. Now, based on these encouraging data from phase 2b study, a phase 3 study was designed and conducted to examine efficacy and safety of tenapanor in patients with hyperphosphatemia receiving maintenance hemodialysis. This was a tenapanor monotherapy. That means tenapanor was not compared with other medications, but with placebo. In this study, tenapanor had 3 different doses during the randomized treatment period for 8 weeks, and then there was 4 weeks of randomized withdrawal period. I'm now highlighting the results of the study in that, as shown here, significant decreases in serum phosphorus in all 3 tenapanor groups from baseline to week 8 happened. And we're looking at the least square mean of phosphorus. So in the 3 milligram dose, for example, tenapanor lowered phosphorus by minus 1.05 milligrams per deciliter, or minus 1.07 and minus 1.00 across all 3 doses. And that happened during the randomized treatment period. During the randomized withdrawal period, these are 4 weeks where tenapanor is stopped, and looking at increase in serum phosphorus. The difference in serum phosphorus change between pooled tenapanor group versus placebo was also significant and was 0.79 in placebo versus 0.07 in tenapanor. So here again, comparing the randomized treatment period, which is the first 8 weeks, versus the randomized withdrawal period, which is the final 4 weeks, and showing that how tenapanor lowered phosphorus in these patients on dialysis effectively, and how serum phosphorus increased after tenapanor withdrawal. Now, the phase 3 study also showed and highlighted and examined the adverse events, and which is known as safety and tolerability. Mean bowel movement frequency remained in the normal range for healthy individuals in all groups throughout the study. At the end of randomized treatment period, mean stool frequency increased by 2.8 times per week. And during the randomized withdrawal period, mean bowel movement frequency was 0.8 to 2.7 movements per week, higher in tenapanor groups versus placebo. And once again, to highlight the safety and tolerability during the randomized withdrawal period, because this is the period that FDA was in particular interested. And as shown here, the safety data in gastrointestinal disorders as well as gastrointestinal disorders by preferred terms have been highlighted. So now, the summary of the results of phase 3 study is that the tenapanor was effective and safe. It's important to note that the protocol was modified after trial was launched at the request of the FDA. The primary outcome was changed from the original design, which was changing serum phosphorus relative to baseline at completion of randomized treatment period, to the revised protocol, which was changing serum phosphorus relative to the end of randomized treatment period at completion to the randomized withdrawal period. And FDA requested a secondary analysis examining the change in serum phosphorus during the randomized withdrawal period among the so-called responders. This study demonstrated that relative safety and efficacy of tenapanor in lowering serum phosphorus through the inhibition of paracellular phosphate transport was the case. And adverse events were limited to those expected by its mechanism, including increasing stool, sodium, and water. Now, I would like at the end to highlight one more study. This is actually what distinguishes tenapanor probably compared to other medications. And this is the so-called AMPLIFY study, a phase 3 study design. A phase 3 study which is designed to look at tenapanor and phosphorus binders together in patients with difficult to control hyperphosphatemia, as shown here. During this study, 236 patients were randomized to two groups, as shown here, placebo versus tenapanor on top of phosphorus binders. Now let's see what the study showed. And now here you're looking at the study results. A total of 228 patients completed the 4 weeks of treatment. And in the full analysis set, with a mean age of 54 years, including 41% women, patients treated with tenapanor plus binder achieved a larger mean change in serum phosphorus from baseline to week 4 compared to placebo. So it was minus 0.84 milligrams per deciliter versus minus 0.19 milligrams per deciliter for placebo. And once again, I would like to highlight these numbers because this is now tenapanor being added to the phosphorus binders and showing that tenapanor can lead to more phosphorus control when it's added to the standard of care. Tenapanor was generally well tolerated in terms of safety and tolerability. 5 patients in the tenapanor plus binder and 2 patients in the placebo plus binders discontinued treatment due to adverse events. No serious adverse events related to tenapanor was reported, and no deaths were reported. So therefore, the summary of AMPLIFY studies that this is the study of patients on stable dose of binders with uncontrolled serum phosphorus concentrations above 5.5 milligrams per deciliter, and additional treatment with tenapanor significantly reduced serum phosphorus concentration from baseline with an observed decrease of minus 0.84 compared to the binders without tenapanor. And there were significantly greater reduction in FGF23, by the way, that I didn't show in any slides, but that was also confirmed similar to prior studies. These data are important. I would like to summarize what we discussed today. We said that hyperphosphatemia is a major independent risk factor for increased cardiovascular morbidity and mortality, including higher all-cause mortality. Clinical practice guidelines recommend lowering elevated phosphate levels towards the normal range. Phosphate binders are currently the only therapeutic class of agents indicated for treating hyperphosphatemia. They act by binding dietary phosphorus, no effect on absorption pathways, and this mechanism requires dosing with meals and snacks and often may lead to pill burden. New understanding of mechanisms of phosphate absorption, the paracellular pathway is the primary mechanism of phosphorus absorption in the GI tract, is important, and it has important implications for evolving and expanding our therapeutic approaches. As shown here, tenapanor was effective in lowering serum phosphorus in patients in terms of monotherapy as well as added to phosphorus to patients who receive already phosphorus binders. Tenapanor was well tolerated in patients with hyperphosphatemia who are on dialysis. And the most common adverse events was diarrhea, and treatment with tenapanor was associated with softening, with stool softening and more frequent bowel movements. Thank you for your attention. Please continue on to answer the questions that follow and complete the evaluation.